Hi, today I want to go over what's going to be the third and final lecture for Chapter 14, which deals with psychopathology and abnormal psychology. Today's lecture is going to focus specifically on disorders of adulthood. To give you a quick overview of today's lectures, what I want to do is I want to start by reviewing some of the points that I made in the very first lecture and actually extend on those. And these are issues that have to do with what do we mean by psychopathology, what do we mean by abnormal behavior, how do we differentiate typical functioning from abnormal functioning. This was an important issue in the first lecture and something that is important to keep in mind as we look at both childhood disorders, which I did in the second lecture, but also today where we talk about adult disorders. Then what I want to do is I want to look at three disorders that are fairly typical or fairly characteristic of adult psychopathology. Anxiety disorders, and there's a number of different disorders that fall under the spectrum or category of anxiety. Mood disorders, which includes primarily depression, but also dysthymia and bipolar disorder. And finally, schizophrenia, which is one of the most significant and profoundly affecting disorders of adulthood. That will be the outline for today, and I'm going to get started now. So in talking about childhood disorders, we review two fairly prototypic, fairly common disorders of childhood, autism and ADHD. Autism, although it occurs in a small percentage of the population, is showing increasing prevalence rates, and ADHD is the dominant or the largest disorder affecting the most number of children. What I want to do today is to focus on adult psychopathology, and as you see on this slide, these are a list of typical forms of psychopathology that are prominent or primarily expressed during adulthood. DSM-5 covers all of these different disorders, but today we're only going to be focusing on a subset of these, and as I did in the childhood section, review descriptions of these disorders, etiologic factors, as well as some of the epidemiology or some of the prevalence rate estimates. Before I get started, I want to show you a graph here that shows what the percentage of lifetime disorders are for a number of these adult disorders broken down by men and women. And what you can see here on the right is the key that gives you the different disorders, starting with major mood disorder, generalized anxiety disorder, panic disorder, phobia, any anxiety disorder, alcohol dependence, substance use, and finally conduct disorder. And what you see here is that for both men and women, the most common disorder would be depression, but that disorder in particular is highly characteristic among women. And then you see the distribution. So what I want to give you a flavor of here is just how relatively prominent or prevalent these disorders are among adults, men and women. Now, adulthood would cover the period from about 18 on, but I want to give you a couple of important pieces of information about psychopathology in the college age range or early adulthood. In a recent survey of 5,000 young adults, both in and recently out of college, almost 50% or nearly 50% of the sample of 5,000 had experienced a form of psychiatric disorder in the past year. So if you recall that statistical abnormality is one of the ways in which we differentiate normal or typical range functioning from pathological or abnormal psychological well-being, that 50% of this sample had experienced a major mental disorder in the past year suggests that a lot of mental illness is not particularly infrequent. But one of the troubling facts about mental health problems both in childhood and adulthood is how few people actually get treatment. In college in particular, fewer than a quarter of people who probably should be getting some form of professional treatment will actually seek treatment. And as I want to talk about in a few minutes, stigma and the concerns of how you'll be judged if you do seek treatment for mental health problems is perhaps one of the most important reasons driving this low rate of people who actually seek and get treatment. So stigma, what is stigma? Stigma is a fairly prominent situation for lots of people dealing with disorders. In the United States, fully a quarter of all American adults, live with some form of a mental illness. Approximately half of Americans will meet criteria for a mental disorder at some point in their life. So again, we're talking about health problems that are very prevalent in our society. one of the things that I've just mentioned is how few people actually seek treatment. And at any point during the lifetime, fewer than 2/3 of all individuals who probably should be receiving some form of mental health treatment because of their illness will receive treatment. So a lot of professional and research attention has been paid to, what is driving this reluctance to seek treatment when it's clearly indicated. And stigma is perhaps one of the best explanations for this lack of treatment. So stigma has been well discussed in the literature, and if you really want to see a very interesting take on what stigma is associated with mental illness, I highly recommend that you watch Ellen Sachs' TED Talk. Ellen Sachs is a law professor at Yale, and she's been dealing with paranoid schizophrenia for most of her life. And despite this major mental disorder, has been able to achieve great success professionally. But her TED Talk gives you a very stark and clear picture of what it's like to live with mental illness and what are the barriers that one experiences, in particular the stigma, both feared and perceived, that people dealing with mental illness often have to experience. So hopefully, having watched Ellen Sachs' video, you have a better sense of what both schizophrenia is, but also what stigma is. And stigma is not just the use of a wrong word or action. Stigma is often characterized as disrespect, or the disrespect that's directed at somebody who is, in this case, dealing with some sort of health problem. It's the use of negative labels to identify a person living with mental illness. And stigma operates or acts as a barrier that often discourages individuals and their families from getting the help they need, primarily due to fear that they're going to be judged or potentially even there'll be recriminations. Ellen Sachs herself makes a number of strong points about stigma. She makes the point that generally we have this uneasiness or this sense of embarrassment about something that might be diagnosed as a mental illness. It often keeps us from seeking treatment. And she says also that even though we know we might need help, especially when we're dealing with a mental illness, mental health treatment is often not well covered by insurance companies. So you get this message from the health system that the treatment for mental illnesses often falls outside of what they consider viable and insurable claims. Okay, now I want to back up and cover some of the key points that I said I would cover based on some of the material from the introductory lecture. And here I want to quickly review again the challenges facing us when we're trying to differentiate problems in everyday living from mental health problems that would be serious enough to warrant treatment. I made the point that one of the ways in which we distinguish psychopathology from typical levels of functioning, including distress, is by judging or evaluating the severity of the distress, but also its duration. Things that are transient, even though they're intense, may not meet criteria for psychopathology or a mental health disorder. Things that last a long time but aren't particularly severe also may not meet criteria. So it's this combination of both severe forms of distress that last longer than we would consider typical, that enables us to distinguish typical range problems or typical everyday distress from more psychopathological conditions. Again, I also talked about the 5 criteria that are used both by science as well as health practitioners to identify abnormal behavior, and those included the 5 that you see here. And I want to quickly run through these again just to make sure these are top of mind. So what are these 5? The first, if you recall, is distress or subjective feelings of distress. And by this I mean these would be the negative feelings that we would report to health providers as a way to try to differentiate what would be considered normal or typical functioning from states that might be defined by mental health illness. So if you're dealing with chronic feelings of sadness, you would be able to report to a professional that this state of distress is different than what you would typically, what you're typically used to, and this might be a clue or a cue to a professional that there might be some kind of underlying mental health problem going on. I also talked about deviance. The idea that specific thoughts and behaviors or emotions would be deviant or deviate from what we would consider acceptable social forms of conduct. So it's this deviance from what we consider typical that sometimes can demarcate problematic behavior or even pathological behavior. So, for example, when we encounter people, often homeless people, who are showing clear signs of a thought disorder, we can often tell both intellectually but also viscerally and emotionally that this person is different than what we're typically used to. It deviates from, or he or she deviates from, what we consider typical behavior. It's important to remember that what might be normal for you might be abnormal for me, and so the context in which we experience individuals who are struggling with mental health problems is very important. In some contexts, having hallucinations, is considered not just normal but also a desirable state. In other contexts, having hallucinations and talking about those may be very atypical and create some of that deviance. Another aspect of deviance is behavior that is dangerous or potentially violent, either towards oneself or directed at others. These would be behaviors that probably would be driven by some underlying mental health problem, but clearly would pose a problem for others in society. This would be a way to demarcate non-normative behavior from psychopathology. And the third criteria I discussed was dysfunction. And by dysfunction, I mean behavior that's maladaptive, that impairs somebody's ability to perform their basic life roles and functions. So does behavior interfere with your ability to respond appropriately in different kinds of situations? Does it interfere with your ability to do things that you expect of yourselves or that others expect of you, like going to school, holding a job, having a social life? So dysfunction, behaviors of psychopathology that interfere with your ability to meet your goals and roles, would be one way of demarcating typical behavior from pathological behavior. I also mentioned the fourth criteria, which is the rarity or the statistical infrequency of certain behaviors, that the idea that different kinds of psychopathology should occur very infrequently, and when we do see them, especially when they conform to certain kinds of diagnostic patterns, we might believe that we're dealing with a real kind of mental health problem, especially if it's a very infrequently occurring problem. However, I've also made the point along the way that a lot of psychopathology, a lot of mental illness is far from rare, and so this criteria may be less useful when we're dealing with certain kinds of disorders like depression, where fully a quarter of all people will deal with a major depressive episode in their life. So statistical infrequency may be an important criteria for things like schizophrenia or perhaps even autism, where it affects fewer than 1% of the population, but much less useful when we're talking about mood disorders like depression. And finally, the fifth criteria we use is when we see behaviors, symptoms conforming to particular kinds of diagnostic patterns. And by this point, you have some familiarity with what I mean by diagnostic categories, the kinds of signs and symptoms and the patterns with which those signs and symptoms co-occur gives us some ability to detect and identify discrete or specific forms of psychopathology. So when we see that a person's behaviors are consistent with these kinds of characteristics that are covered in diagnostic systems, we have some confidence that what we're seeing is a form of psychopathology that's both rare but also potentially related to an underlying mental health problem. All right, let's start now by talking about anxiety and a variety of the different disorders that fall under the category of anxiety. So what are anxiety disorders? Generally, anxiety disorders are characterized by intense and pervasive feelings of fear, a sense of dread, but what's important is this is a sense of fear and dread in the absence of any clear, true, and immediate danger. Anxiety disorders are reasonably prevalent in the United States. Approximately 18% of all individuals will experience an anxiety disorder at some point in their lifetime, and fully a third of all individuals who deal with an anxiety disorder will have the first experience or first episode of anxiety by early adulthood, or about 21 years of age. One of the things we know about anxiety disorders is that they frequently co-occur with both depressive disorders. The highest comorbidity is with depression, but also co-occur a lot with substance use and abuse disorders. Most people with anxiety disorders, we know, will have a second kind of anxiety disorder. So it's rarely the case that if you're diagnosed with, say, a generalized anxiety disorder, that you won't at some point in your life experience a second kind of anxiety disorder. Now, in a second, I'm going to start walking through some of the specific anxiety disorders. But before I do, let me actually just sort of set the frame for a little bit of what we know to be the etiology or the causal processes that underlie most anxiety disorders. Again, as in most of the disorders that we've covered so far, we can look to both biological, psychological, and cognitive factors, as well as environmental or situational and contextual factors to understand the causal origins of anxiety disorders. Cognitive models or cognitive causal models have been very prominent in the literature, and what we know is that individuals who are prone to anxiety disorders are individuals who are prone to perceive ambiguous and even neutral situations as much more threatening than non-anxious individuals. So if you have that vulnerability, this vulnerability to perceive situations, ambiguous or neutral situations, as threatening, you're somebody who's more prone to a particular kind of anxiety disorder. Anxious individuals often deal by responding to certain kinds of situations and generalizing from one situation to the next. So if you experience one situation as potentially distressing or stressful or fear-inducing, people who are prone to or likely to develop an anxiety disorder are also likely to generalize those feelings from one context to the next. And finally, we know that there are important underlying biological characteristics that increase the predisposition for anxiety. And when I look at the specific disorders in a second, I'll highlight some of these biological vulnerabilities. Well, let's start by looking at social phobia, which is one of the more common forms of anxiety disorders. Social phobia is the fear of being judged or becoming embarrassed by others. And individuals who are dealing with social phobia are individuals who are likely to avoid all social situations and in the process often become very reclusive for fear of experiencing or encounter other people's judgments. Now, one of the things we know is that if you look at college students, nearly a half of all college students will report feeling some significant amounts of shyness, but only a small percentage of that, or about 20%, would show real symptoms that would qualify for the diagnosis of social phobia. And only about 7% of all individuals will have a diagnosable form of social phobia. So while social phobic symptoms may be somewhat more common in the general population, with upwards of 18% of individuals, say in the 18 to 25-year-old range, showing symptoms that would be characteristic of diagnosable social phobia, only about 7 to 8% of individuals will be diagnosed with it during their lifetime. So where might phobias like social phobia come from? What would be some of the etiologic evidence that we have? Well, one of the things we know looking at cognitive explanations is that individuals who are struggling with social phobias and different kinds of phobias have excessively high standards, especially that involve social performance. So there's this vulnerability that you're going to be judged, or this assumption that you're going to be judged harshly because it's impossible to meet those standards. Why would anybody not judge you harshly if you can't meet those abnormally high social standards? Another thing that we know is that cognitively individuals dealing with phobia are highly attentive to signs for social rejection or signs of social rejection. So they look to others for any hint of or any evidence that this person might be even mildly critical of somebody in a social situation. So cognitively there's this predisposition to both look for and to hold on to evidence that might conform with or confirm that you're falling short of these high standards. In terms of biological factors, one of the things we know is that there is a genetic vulnerability, in particular genetic vulnerabilities that operate in areas of the brain such as the amygdala, that's the fear processing centers of the brain. And we know that certain genetic vulnerabilities seem to lead to the amygdala responding both quickly and also very strongly in certain kinds of situations, including more neutral situations. So one of the things we've been able to establish through both behavioral genetics research designs, but also to some extent some molecular genetic studies, is that there seems to be a genetic vulnerability for certain individuals to develop overly sensitive amygdalas, which make them vulnerable to rapid fear response. Well, probably as much as cognitive and biological theories of the etiology of phobias, behavioral theories of phobia probably have been both the most studied and perhaps where we see some of the strongest evidence for how we develop different kinds of phobias. And behavioral theories of classical and operant conditioning, which you may recall from one of the earlier chapters, have been shown to be important factors in the development of different kinds of phobia. You may recall from that lecture, those lectures, that classical conditioning leads to fear of different kinds of objects, whereas operant conditioning helps to maintain that fear. Under conditions of classical conditioning, this involves making associations between an involuntary response and a stimulus. So if you remember from the Pavlovian examples, a dog salivating at the sound of a bell, whereas operant conditioning is really about making an association between some kind of involuntary behavior and the consequence. So praising a dog when he fetches the ball and withholding praise when he doesn't. So classical conditioning leads to fear of a certain kind of object when it's paired with a naturally frightening event. For instance, when a child falls in a river and he or she can't swim, this will lead to a natural fear or phobia of water. And operant conditioning will lead to the avoidance of those kinds of situations as a way to minimize anxiety. So as you see from this slide, some of the early work in this was done by Watson and Skinner in terms of their different forms of experiment. And the video that you see here, and you should be able to watch, is an old film but shows exactly how the famous little Albert that went from being unafraid and showing no signs of phobia for things like rats and rabbits to being conditioned through classical techniques to be afraid of rats. It's a nice example of how, especially early on in life, that fear can be conditioned, which then subsequently can lead to diagnosable forms of phobia. All right, let's turn to a different anxiety disorder and specifically talk about post-traumatic stress disorder, or PTSD. PTSD is perhaps one of the most significant disorders given some of the behavioral symptoms that define it. And by post-traumatic stress disorder, we're generally talking about the kinds of symptomatology that somebody is left with after they've experienced a traumatic event or some form of extreme stress, where really what they've encountered is a threat to their mortality or their life. The core symptoms of PTSD include the re-experiencing of the traumatic event. So you have individuals who report intrusive thoughts, nightmares, and flashbacks that make them feel like they're living that event over again. Second, emotional numbing and detachment. Individuals dealing with PTSD symptomatology will often say that what they don't want to do is think or feel the event again, so they become emotionally detached. And this detachment or numbing often gets generalized to all sorts of situations and all sorts of people. And the third criteria are symptoms of hypervigilance and chronic arousal. People who've experienced traumatic events and are dealing with PTSD often show this hypervigilance that leads to, for instance, difficulty falling asleep, being very aware of their surroundings and sometimes overly vigilant in their surroundings, and also these hyper startle responses, so that even in a quiet environment, any subtle sound or noise might make them overly aroused physiologically. These would be the three primary characteristics of somebody who's dealing with PTSD. Now, the etiology of PTSD is somewhat easier to understand than some of the other disorders, primarily because we're often looking at real, natural occurring events or events that are objectifiable. For instance, natural disasters. Individuals who experience natural disasters such as hurricanes, tornadoes, earthquakes are often individuals who are very vulnerable to experiencing or being diagnosed with PTSD. But also other forms of experiences such as physical and emotional abuse, especially sexual abuse, can often be a real precipitant of PTSD symptomatology. So you often see PTSD symptomatology in rape survivors or individuals who've been physically accosted. Now, traditionally or historically, we have thought about PTSD as the diagnosis of combat veterans, individuals who experience combat or war-related traumas. people who've been exposed to different horrors of war are often individuals who will develop PTSD. As recently as the Afghanistan war that we're still somewhat involved in, and in Iraq, 13 to 20% of all veterans returning met criteria for PTSD. Now, unfortunately, in situations of war, it isn't just soldiers or people who are involved in combat, but often civilians themselves who are exposed to the horrors of war. In the Afghani conflict, somewhere in the neighborhood of 1/5 of all Afghan citizens right now meet diagnostic criteria for PTSD. So I highly recommend that you take a minute and stop the lecture and watch this YouTube video that deals with PTSD and puts PTSD in the context of war. I think you'll find it interesting, both in terms of helping you understand what PTSD is and who's likely to experience it, but in particular how war and situations of war and then coming back from the theater of war is often where individuals will experience their PTSD. So one of the big questions in the research literature and the clinical literature trying to understand the etiology of PTSD is the search for what risk factors or what particular kinds of vulnerabilities might make somebody more or less vulnerable to develop PTSD in response to these different kinds of disasters. So we've looked at social factors such as characteristics of the actual traumatic event to understand the nature of the kind of event that might lead to PTSD. We've also looked at other social factors like the kind of social support that's available to individuals after they've experienced these traumatic events as a way to understand who's most vulnerable to PTSD. So we know from research with men and women who've experienced physical or sexual abuse that individuals who report high levels of social support after the trauma are often much less likely to develop PTSD. We also know that psychological factors increase and or decrease the likelihood of developing PTSD. So individuals who report high levels of pre-existing subjective distress before the natural disaster is experienced are often much more vulnerable to develop PTSD, as well as people who report a vulnerability to feeling less control in their lives. Individuals who report feeling out of control or less likely to have a control over their life circumstances when they do experience natural disasters or traumas of different kinds are an increased likelihood of developing PTSD. And finally, we also know that biological factors, in particular physiological states of hyperactivity or hyperreactivity, have been linked to the likely development of PTSD following stressful or traumatic events. To a lesser extent, we believe that there's certain genes, some of the genes that operate in the amygdala or other areas of the brain that process fear, might be making people vulnerable to certain kinds of traumatic events, but that research literature is still reasonably new. Let me talk now about generalized anxiety disorders. In contrast to specific phobias and PTSD, which are specific reactions to fears of certain situations or reactions to specific events, generalized anxiety disorders are considered excessive and non-specific types of anxiety and worrying, fear about controlling situations. And these are symptoms that are characteristic of individuals who are of both anxious and afraid in all sorts of situations and carry those fears into many different situations. Symptoms of generalized anxiety disorder include restlessness, easy fatigue, problems with concentration, mood irritability, chronic states of tension, and difficulties with steady sleep. So in terms of etiologic theories of generalized anxiety disorder, we've probably gotten some of the best evidence from different cognitive theories. In particular, cognitive theories have helped us to understand the kinds of conscious and unconscious thought processes that might make individuals both vulnerable to develop generalized anxiety disorder, but also help us to characterize the cognitive processing of individuals with generalized anxiety disorders. And one of the things we've learned is that individuals prone to generalized anxiety disorder are likely to focus on, even in neutral situations, situations of their context, bodily cues that create a sense of threat, dread, or worry, and this does lead to chronic states of hyperarousal. And an interesting study that used the Stroop color naming task that you've probably been exposed to already in this class. One study presented threatening and non-threatening words to generalized anxiety disorder patients as well as non-patient controls, and did so on a computer screen, but for very, very short periods of time, 20 milliseconds, so a period of time that's too short for any of the participants to consciously be able to process the content of the word. So for generalized anxiety disorder patients, we found that they were slower in naming the colors of words that were threatening than the non-patients. But the two groups didn't differ in terms of the time it took for them to name the colors of non-threatening words. So this suggests that people with generalized anxiety disorder seem to be chronically vigilant or always vigilant for signs of impending threat, even at an unconscious level. And we could see that in terms of the reaction times that it took for them to name the colors when it was attached to a threatening versus a non-threatening word. Okay, and looking finally at one of the last of the anxiety disorders, OCD or obsessive compulsive disorder. Here we're talking about a disorder that's characterized by the presence of obsessions. And by obsessions, I mean recurrent and persistent thoughts, impulses, or images that are very intrusive but also very inappropriate and are very difficult to ignore. So, for example, individuals who are struggling with obsessions are often hyper afraid of or hyper concerned with the contamination of germs. The idea that they'll come in contact with germs and become physically sick is a constant worry, a constant obsession. And one of the things that people develop in response to these obsessions are what we call compulsions, which are repetitive behaviors or even mental acts that that person feels compelled to use or perform as a way to deal with, to minimize the impact of that obsession. So for individuals who might have this chronic obsession about the potential contact with germs, they might develop compulsions that include excessive hand washing. One of the things about obsessive compulsive disorder is that if you know anybody who's dealing with an obsession and a compulsion, it's very easy to see that their lives become very organized around that obsession and the compulsions needed to manage it. But one of the things we also know is that it's not just a very pronounced when it's there, but it's also fairly prominent. And there's plenty of examples, both in the research literature but also in the popular press, of individuals who struggle with it. And one of the most recent and high-profile examples of that is the case of Howie Mandel, who made his struggles with OCD known to the public as a way to try and help deal with the stigma of it. And if you take a few minutes to watch this YouTube video, I think you'll find it interesting to see how somebody as prominent as Howard Mandel struggled with and deals with OCD-type symptomatology. All right, I've been talking primarily about anxiety disorders. Now I want to switch and talk for the next couple of minutes about mood disorders, in particular depression, dysthymia to some extent, and also bipolar disorder. Let me start by first reviewing a point that I made right at the outset of this lecture, that there's a high comorbidity or a high co-occurrence between anxiety disorders and depressive or mood disorders. In fact, the two highest comorbidities known in the adult psychopathology literature are between depression and anxiety. One of the things that depression and anxiety both have in common, and it's probably why we see them co-occurring so often, especially in adults, is that both are characterized by high levels of psychological distress, psychological and emotional distress. But we've come to understand some important differences between these two, and it's why we think of these as two very discrete or different kinds of pathologies. Depression, in contrast with anxiety, we find is uniquely related to states of anhedonia or sadness, whereas in contrast, anxiety and anxiety symptomatology is more highly associated with states of physiological hyperarousal and not necessarily associated with sadness. So individuals who are dealing with depression may not report these chronically elevated states of arousal, and in contrast, individuals dealing with anxiety won't generally report states of sadness and distress of that kind. So we believe that by focusing on these two core features of anxiety and depression, we are better able to separate these two. And it's with this focus on anhedonia and sadness that I want to begin talking a bit about what we mean by major depressive disorder. So mood disorders, as I showed you in the graph at the early in this lecture, mood disorders include depression, major depressive disorder, dysthymia, and to a lesser extent bipolar disorder. But these tend to be the most prevalent forms of psychopathology experienced by adults during the lifetime. So major depressive disorder or major depression is characterized by severe negative mood or a lack of interest in what we think of as normally pleasurable activities. Symptoms of major depression include serious disruptions in sleep, serious disruptions in eating and hunger, as well as chronic states of fatigue, loss of energy, and cognitive and emotional feelings of hopelessness. Dysthymia is sort of a lesser, if you will, a lesser version of major mood disorder. It's defined primarily by long-lasting states of sadness that may be less intense and don't often carry with them some of the other secondary features like disruptions in sleep and eating, loss of energy. But one of the things we know about dysthymia is that it tends to last a lot longer for individuals than episodes of major depression. Bipolar disorder is known also as bipolar manic depressive disorder, and it's characterized by alternating periods of depression and mania, and I want to talk about each of these in turn. So mood disorders, as I've made the point now already, is a very prominent and prevalent psychopathology. Approximately 10% of the United States population in the 18 years of age and older range will experience a major mood disorder in any given year. We know from large population studies that about 30% of all adults will experience in their lifetime a diagnosis of major depressive disorder in particular. The median age of the onset of the first depressive disorder is somewhere in the late 20s, early 30-year-old age range. And what we know about mood disorders is that they often co-occur both with anxiety disorders, but substance abuse disorders as well. We can easily understand the relationship between mood and anxiety disorders, as I just have talked about, but the relationship between mood and substance abuse is also one that's been well studied, and theories suggest that substance abuse develops secondarily to depression as a way to cope with mood disturbances. In terms of depressive disorder specifically, one of the things we know is that it affects women at a rate of 2 to 1. So twice as many women will experience depressive disorders in their lifetime than men. And one of the things that we've come to understand is that there are important psychological and psychosocial differences between men and women that increase women's vulnerability to depression. In particular, gender roles and some of the challenges confronted by women often make women much more vulnerable to internalizing problems such as depression versus externalizing problems such as conduct disorder and antisocial characteristics, which tend to be more prototypic of men. We've also seen that depression occurs in all sorts of cultures, even though one of the things we've also found is that depression may express itself differently depending on somebody's culture of origin. For instance, in Central and South American cultures and to some extent in East Asian cultures, depression is often experienced in a much more somatic or physical sense. And when people describe symptoms of depression, say in Central and South America, they often talk about pains of the heart, where they're locating physical sensations in areas that we associate with emotion. So depression, while characteristic or prevalent in lots of different cultures, the symptoms of and the way in which the distress is expressed may be different depending on somebody's culture. In contrast to major depressive disorder, bipolar disorder is a much less common form of psychopathology. It occurs much less frequently, and we see a lifetime prevalence of roughly 3 to 4% versus a lifetime prevalence of close to 20% in the case of depression. Bipolar disorder, or manic depressive disorder as it's more commonly referred to, is a cycling combination of depressive episodes following by manic episodes. And by mania, I mean periods of severely elevated mood, increased anxiety, diminished need for sleep, and often carries with it these characteristics that we associate with grandiosity, incredible ego structure, racing thought, and extreme distractibility. So periods of depression are often followed by these much shorter periods of manic, heightened energy, which then give way to depression again. So bipolar disorder is often defined as this cycling pattern of periods of profound sadness, followed by shorter periods of elevated mood, again, then these collapses into periods of depression. Probably in ways that schizophrenia is such a debilitating disorder, bipolar disorder, because it carries with it these manic states of loss of control and sometimes even psychotic delusional states of mania, is also a profoundly debilitating mental health problem. One of the best spokespersons for bipolar disorder is a psychologist by the name of Kay Redfield Jamison, and Dr. Jamison was a professor at UCLA, and in the last 10 years since she published a very influential book, has essentially been going around the country, both continuing to do research on bipolar disorder, but talking about what this condition is. And this YouTube video that I have linked here is a wonderful example of Dr. Jamison talking about the core symptoms of bipolar disorder, the way in which it can affect one's lives, and what we know to be some of the important causal theories about bipolar disorder. If you take a few minutes to watch it, I think it'll give you a good flavor for what this highly debilitating disorder is. So what about the etiology or the causal factors for mood disorders? What do we know? Again, as with all the different pathologies, we can look to both psychological or cognitive, contextual, as well as biological characteristics. When we think about the cognitive bases for mood disorders, we're often focusing on what's been called the cognitive triad, or this idea that people's cognitive views, perceptions, and ideas become highly distorted as they relate to oneself, as they relate to how people perceive the world and perceive the context that they're in, but also, importantly, thoughts and beliefs that they hold about their future. So this set of three cognitive triad kind of ideas about self, context, and future tend to be one of the ways in which we've come to understand both how people are vulnerable to develop depression, but also the characteristics of depression. Another cognitive model of depression is what we call an attributional model of depression, where people's attributional styles, or the way in which they try and make sense of and explain their lives, increase the risk of depression. So people over the course of their lifetime may develop what we consider a self-blaming or a highly self-critical attributional style. And when they encounter certain kinds of stressors, this increases the risk that they're going to develop a depressive response. We also know that there are important contextual factors or theories that lead to both the increased likelihood of depression or that also explain why depression might occur. We know, for instance, that living in conditions of high stress, chronic stress, both on a daily basis, but also where you have significant life challenges such as poverty or low socioeconomic resources, or you experience certain kinds of disruptions like job loss, divorce, the death of a family. These kinds of situational stressors can sometimes trigger a depressive, disordered response. We also know that contextual social isolation, or being isolated interpersonally from others, can be a real vulnerability and lead to depression. In terms of biology, we know that depression and mood disorders in general, in particular bipolar disorder, carry with them a clear genetic basis where we see increased likelihood of a mood disorder among a first-degree relative, in particular a dizygotic or identical twin, when one twin has a particular disorder. So the concordance between identical twins is 2 to 3 times higher than for depression than you see in fraternal twins. That concordance is even higher when talking about bipolar disorder. So if one identical twin has a bipolar disorder, your identical twin is 60% more likely to develop that diagnosis than you would see in fraternal twins, where that risk is about 13%. So these genetic studies give us fairly clear evidence that there's a genetic basis, but this shouldn't be surprising since most of what we've been talking about has some form of genetic basis, but we're still trying to understand what are the key genes that might be implicated in mood disorders. Continuing with the neurobiology of depression, probably the strongest evidence in support of a biological cause for a mood disorder, in particular depression, comes from the work on neurotransmitters such as serotonin. Serotonin levels, especially depleted levels of serotonin in the brain, have been related to both symptoms of depression, but as well important behavioral consequences of depression, such as suicidal ideation and suicidal behavior. So one of the things that we know is that individuals who are dealing with depleted levels of serotonin, and we can come to have depleted levels for a variety of physiological reasons, are often vulnerable to depression. And so not coincidentally, some of the most effective interventions for depression target recalibration of serotonin systems in the brain through different kinds of medications. Okay, now I want to shift finally to a few minutes to discuss schizophrenia, which perhaps is one of the most profound mental health problems that we know of in terms of how debilitating and incapacitating it can be for individuals who are dealing with it, but also we know that the consequences on family that try to take care of individuals with schizophrenia is also quite profound. Symptoms of schizophrenia, in particular symptoms of psychosis, which are some of the core, or is one of the core aspects of schizophrenia, have a profound effect on people's mood, their thought, their perceptions, and their consciousness. So when we talk about schizophrenia, we're generally talking about significant thought disorder characteristics. There are a number of different subtypes of schizophrenia, which I'll review in a second, but one of the things we know is that it tends to have its onset, schizophrenia tends to have its onset in the late teens and early 20s. Generally, we know that schizophrenia affects men and women at about an equal rate, and as I've said earlier, it's a low-frequency mental health disorder affecting only about 1 to 2% of the population in the United States. But interestingly, when we look at it in terms of treatment and the cost associated with treatment, treatment for schizophrenia accounts for over 60% of all the mental health dollars spent treating a mental illness. So what are the core symptoms of schizophrenia? We generally think of schizophrenia as having two different types of symptoms, what we call positive symptoms and negative symptoms. One way to think about what positive symptoms are is that these are symptoms that are in excess or that are excessive in the way in which a person is functioning. So individuals with schizophrenia tend to have excesses and delusions, hallucinations. Their thoughts tend to be very loose. Speech patterns are highly disorganized and often quite meaningless. And when we look at their behavior or behavior patterns of individuals dealing with schizophrenia, behaviors are very erratic, very disorganized. In contrast, the negative symptoms of schizophrenia we tend to think of as deficits in functioning. So we tend to see the negative symptoms including apathy or a lack of interest, showing a lack of emotion, blunted emotion, sort of absent, vacant kinds of emotion. We tend to see very slowed and impaired speech processes, as well as very slow and impaired movement. So even though there'll be disorganized behaviors, tends to be disorganized behaviors at a very slow tempo. So it's these combination of positive and negative symptoms that are hallmark of what we call schizophrenia. And before going on to talk a little bit about some of the etiologic features of schizophrenia, what I would love for you to do is to take a few minutes and watch this YouTube video on a very famous case study, schizophrenia case study, known as Gerald. And Gerald was an inpatient at the National Institutes of Health a number of years ago. It's a slightly dated film, but it really gives you an up-close and personal view at what the active symptoms of schizophrenia might be in somebody who, even though heavily medicated, you can still see just how profoundly affecting schizophrenia symptoms might be. So as you heard in the film on Gerald, Gerald would be considered somebody dealing with paranoid schizophrenia. So there are a number of different subtypes of schizophrenia, and the diagnosis of the kind of schizophrenia somebody might have would be based on the particular pattern of symptoms that he or she might be expressing. There are 5 different types of subtypes currently. Paranoid schizophrenia is generally marked by delusions that are predominantly of a persecutory nature. So people are often reporting that they're feeling persecuted, chased, reliving in chronic fear that somebody is out to get them. Catatonic schizophrenia is marked by severe motoric abnormalities and often grossly slowed and impaired motor functioning. Disorganized schizophrenia is marked by a loss of reality and inappropriate affect. So individuals who, regardless of delusions or hallucinations, are generally seen very out of touch with reality. Probably many of us have encountered individuals dealing with disorganized schizophrenia, often homeless individuals who seem to be in their own world, talking with themselves or somebody, and altering between periods of elevated mood and despondence. These would be characteristics of disorganized schizophrenia. Undifferentiated schizophrenia is schizophrenia that really is not one of these things, but many of these things, and it's marked by multiple features and is relatively common along with paranoid schizophrenia. When we think of schizophrenia over the lifetime, we're also interested in the residual effects of schizophrenia. So sometimes individuals may have a single psychotic episode, but then will be living with the consequences of some of those effects. We don't think of that as a subtype of schizophrenia, but what we often think of is that the schizophrenic experience leaves this residue including negative symptomatology, that can have a lasting effect. Okay, what about the etiology or causal factors for schizophrenia? In much the way that autism, that I talked about in my second lecture, is thought of as a brain disorder, and to some extent ADHD of a disorder of regions of the brain, schizophrenia is generally thought of as a neurobiological disorder, or a disorder that's primarily occurring in the brain. We know that the brains of individuals with schizophrenia are often very different than the brains of neurotypic or non-schizophrenic patients. One of the things that we often see are changes in white and gray matter proportions. We also see differences in the size of certain areas of the brain. So we know there are to be important structural differences in the brains of individuals with and without schizophrenia. We also know that there's an important genetic basis for schizophrenia, and that these genes and these genetic vulnerabilities are expressing themselves in the structural abnormalities of the brain. So we know that even though schizophrenia is a very infrequently occurring pathology occurring in roughly 1 to 2% of the adult population, it tends to be highly concordant in monozygotic twins. So we see a high degree of heritability for schizophrenia, especially in first-degree relatives. But despite the clear biological basis, brain basis for schizophrenia, there's also important evidence that schizophrenia may be, and the vulnerability to schizophrenia is very responsive to the contexts in which individuals live in and the kinds of environmental factors that people are embedded in. So we know that genetically vulnerable individuals may often be at risk given certain kinds of environments, and it's these kinds of environments that we think of as often imposing a risk on the vulnerable individual. In particular, urban environments and the kinds of stresses associated with urban living, poverty, crime, noise, pollution, these would be considered, on top of the underlying biological vulnerability, a double risk factor, and the diathesis, or the trigger for that underlying diathesis. Work that's been done to try and understand the familial contributions, etiological contributions to schizophrenia, have generally not found strong conclusive evidence that families cause depression. But one of the things we have found is that certain communication and emotional patterns in families tend to be fairly characteristic of families dealing with a schizophrenic family member. In particular, patterns of what we call expressed emotion has been highly correlated with schizophrenia. Families that are high in expressed emotion are often characterized as being very over-involved and very overprotective in the lives of family members, and very critical in terms of how they voice both dissatisfaction and expectations towards family members. Now, we don't know that this is necessarily causal or causes schizophrenia, but it probably is something that is part of those environmental characteristics that might lead a vulnerable individual to have their first lapse or first experience of a schizophrenic episode. So high expressed emotion is a family environment and emotion and communication patterns that tend to be very critical, hostile, and resentful, and are very likely to be the kinds of triggers for individuals who have these vulnerabilities. But also, these are the kind of environments when schizophrenic patients go back, they're at increased vulnerability for relapse given these kinds of expressed emotion environments. And finally, in the way that environments, in particular urban environments, have been correlated with schizophrenia, there are causal models that suggest that social class, in particular socioeconomic class, may be an important risk factor for schizophrenia. Now, it isn't that poverty per se is causal to schizophrenia, but it may be an important risk factor. So one of the things that we found is that individuals who deal with schizophrenia or who are dealing with schizophrenic symptomatology are often individuals who are living in lower and lower middle socioeconomic conditions. But one of the things that we're not quite sure of is this where somebody started. So individuals with schizophrenia may be just as likely to develop their first episode, whether they're in a middle class or upper middle class family, as they will in a lower middle class family or even lower socioeconomic strata. But one of the things that we know happens as a result of schizophrenia is that people will start a downward drift towards lower socioeconomic conditions. And once in these lower socioeconomic conditions, situations that are defined by fewer social supports, fewer resources, and clearly less access to treatment, these conditions of chronic stress, chronic challenge will exacerbate the situation for individuals who are dealing with schizophrenia. So this social class hypothesis or this social drift hypothesis is better thought of not as a causal factor for schizophrenia, but rather something that may play a role in maintaining schizophrenia or exacerbating the negative consequences of schizophrenia. Okay. So this brings me to the end of the lecture, and just to recap, I started the lecture by reviewing some of the key points that I introduced in the first lecture on Chapter 14 in terms of what do we mean by psychopathology, and importantly, how do we differentiate typical normal range functioning, including normal range distress, from distress that becomes pathological, debilitating, and potentially diagnosable as a form of mental disorder. And then today, focusing on adult pathology, I complemented what I had talked about in the second lecture in terms of childhood disorders, including autism and anxiety. Today, my focus was on adult pathology, different forms of anxiety disorders, mood disorder, in particular depression and bipolar disorder, and then finally finishing up with schizophrenia. So this is the third and final lecture for Chapter 14, and the next chapter in your book is Chapter 15, which deals with the treatment of psychopathology. Thank you.